we are seeing the testicular carcinoma series. This is the testicular carcinoma part 3. Okay, in this video, we are going to see the clinical staging, the imaging, which are used for the staging, that is CT, the role of PET CT, etc. And third, we are going to see the pathological staging and chest imaging, some points about serum tumor markers, and at last, sperm cryopreservation. Okay, let's discuss about the clinical staging. The clinical staging is divided into clinical stage 1, 2, and 3. The one stage means that the tumor is confined to the testis. Tumor is confined to testis. Clinical stage 2 means it has metastasis to the regional lymph nodes. Regional lymph nodes. That means retroperitoneal lymph nodes. Stage 3 is spread to non-regional or visceral lymph nodes, visceral metastasis. So this is confined to the testis. This is stage 2 is metastasis to the retroperitoneal lymph nodes. Stage 3 is visceral metastasis. Coming to the imaging for staging, the imaging which is most commonly used for staging is contrast enhanced CT scan, CECT. Okay, before going into this, we need to know some basic things about germ cell tumors. First, germ cell tumors have a predictable pattern of metastatic spread. Predictable pattern of metastatic spread. That means that is the testicular tumor. From testicular tumor, the metastasis will reach to retroperitoneal lymph nodes. From retroperitoneal lymph nodes, it will go into the cisterna chyli, and from there, it will go to the thoracic duct and ultimately to the left supraclavicular lymph nodes. Okay, this is the metastatic spread, that is an orderly spread. The exception to this is choriocarcinoma. Choriocarcinoma mostly spread by hematogenous spread, mostly to the brain. Another point to note is that for brain metastasis, if there is brain metastasis, we should always keep in our mind the suspicion of choriocarcinoma. The second thing we want to know is the pattern of lymphatic drainage in the retroperitoneum. Retroperitoneal lymphatic drainage. The retroperitoneal lymphatic drainage is from right to left. So here I will put a diagram, and so that you can able to follow it very easily. So let's consider this is the IVC. This is the right renal vein. This is the left renal vein. This is the right renal vein, and this is the aorta, which lies behind the left renal vein. So on the right side, this is the IVC. In the left side is the aorta. So let's see the pattern of metastatic spread. For right-sided testicular cancer, the metastatic spread goes to the paracaval lymph nodes, interaortocaval lymph nodes, and then to the para-aortic lymph nodes. From here, from the right side, it is going to the end of the left side. Let's see the left-sided testicular carcinoma lymphatic drainage. So left-sided testicular carcinoma drains into the para-aortic lymph nodes and then to the interaortocaval lymph nodes. It will not spread beyond this thing. It will not cross the right side. So the pattern of lymphatic drainage in the retroperitoneum is from the right to left, as I have told before. So these are the things which you should know before interpreting the CT of the retroperitoneum. So what are the advantages of doing CT scan? CT scan helps CT scan helps in the diagnosis of metastasis to the regional lymph nodes. So for diagnosis of lymph node spread to retroperitoneum, that means it helps in staging and also helps to determine if there is any anatomical anomalies. Then the next question comes: what percentage of lymph nodes will be found in retroperitoneum in seminoma and non-seminoma germ cell tumors? For seminoma, it's around 10 to 20% of the cases we will find lymph nodes in the retroperitoneum. For non-seminoma germ cell tumors, it's around 60 to 70%. And then, what is meant by a significant lymph node? In CT, we can find many lymph nodes in the retroperitoneum. So, what is the lymph node which contains the metastasis? This is called the significant lymph node. So, lymph node which is 5 to 9 mm in size in the primary landing zone. Primary landing zone is considered as a suspicious lymph node. Beyond this primary landing zone, that is, these are the zones, primary landing zones. Beyond this primary landing zones, if the lymph nodes are more than 10 mm, that is 1 centimeter, it is known as a suspicious lymph nodes. Particularly if these lymph nodes, suspicious lymph nodes, are anterior to the great vessels, it is most probably a metastatic lymph node. What is the role of PET-CT in the treatment of testicular carcinoma? PET-CT has no role in the routine evaluation at the time of diagnosis. No role at the time of diagnosis. But in testicular carcinoma, PET-CT is used in one situation. I will tell that situation later. Let's see the subclassification of clinical stage 2. Subclassification based on the CT finding. Subclassification. So clinical stage 2A, 2B and 2C. If the lymph node size is less than 2 cm, it is 2A, 2 to 5 cm and more than 5 cm. Coming to the pathological staging. Pathological staging. This pathological staging is done only after RPLND, retroperitoneal lymph node dissection. So let's see what are the indications for retroperitoneal lymph node dissection. It is done for clinical stage 1 and 2 non-seminomatous germ cell tumor. It's only done as a staging procedure. not as a procedure with a curative intent, not for curative intent. For these stages, the RPLND is done only to determine the need for chemotherapy. Okay. So pathological lymph node N1 is less than 5 lymph nodes, but these lymph nodes are less than 2 cm. Pathological N2 is more than 5 lymph nodes, or if the lymph nodes are between 2 to 5 centimeters. Pathological N3 is when the lymph nodes are more than 5 centimeters. This pathological staging of nodes is not done for post-chemotherapy status. For post-chemotherapy RPLND, this pathological staging is not done. So coming to the chest imaging. For all cases, you do the chest imaging, that is X-ray of the chest. So which cases we need CT chest? Let's see the indications for CT chest. If the patient has increased serum tumor markers, at that time we will do a CT chest. If there is any identification of metastasis in physical examination, or CT of abdomen and pelvis, at that time we can go for chest CT. Suppose if there is any suspicious lesion in the chest X-ray, at that time also we can go for chest CT. And when the patient have lymphovascular involvement or embryonal carcinoma status in the biopsy, at that time also we can go for CT chest. Suppose if the patient is having a hilar, when doing the CT chest, if the patient is having a hilar lymphadenopathy, but not a retroperitoneal lymph node, retroperitoneal lymph nodes are not there. Patient is having hilar lymph node but not the retroperitoneal lymph nodes. At this stage, the other differential diagnosis of metastatic testicular carcinoma is taken into consideration. These different diagnoses are lymphoma or sarcoidosis. In these cases, we should do mediastinoscopic biopsy to rule out the germ cell carcinoma. Some points about serum tumor markers. These serum tumor markers are done within 4 weeks of orchidectomy. Within 4 weeks. If there is persistent serum tumor marker elevation, it indicates that it is a metastatic disease, so that we can go directly for induction chemotherapy. For metastatic testicular tumor, the classification system which is used is IGCC-CG group classification. This IGCC-CG classification is discussed in the previous videos. Please go and check out those videos. In that classification, for seminoma, there is no poor risk group. This IGCCG group has good prognosis group, intermediate prognosis group, and poor prognosis group. For seminoma, poor prognosis group is not there. Only for non-seminomatous germ cell tumor, the poor prognosis group is there. This system scores over TNM staging for metastatic testicular tumor. Scores over TNM staging, because the TNM staging does not consider the differences in prognosis between seminoma and non-seminomatous germ cell tumor with non-pulmonary visceral metastasis. So, this classification is used. Coming to the sperm cryopreservation. all patients who is going for chemotherapy or radiotherapy or retroperitoneal node dissection, sperm cryopreservation should be done. 52% of testicular carcinoma cases have oligospermia, and 10% of the cases has azoospermia. After chemo, all patients will be having azoospermia. So recovery after radiotherapy will be seen only after 2 to 3 years. Patients undergoing RPLND has 80% chance of ejaculatory dysfunction. So these are some of the points which denotes that all patients who is going into the treatment of testicular carcinoma should undergo sperm cryopreservation. Thank you for watching this video. Please give a like and subscribe to this channel for more videos. Thank you so much.